There's also been reconfigured in East Sussex, so we no longer have stroke services provided at the Conquest. They're all provided out of Eastbourne. So, however, the ones that haven't been reconfigured over the past few years are the Worthing and the St Richard's sites. So they remain as they have been. There's been improvements, but they've not been formally reconfigured. So we've been asked by our commissioners, the CCG, and now turning into the ICS to participate in a stroke services review, which is ongoing. It doesn't just cover what we do, it covers prevention of stroke and rehabilitation as well, but there is a focus on the acute care element. Back in about this time last year, April 2021, a kind of case for change was developed, which outlined the why we were doing what we were doing, that was signed off by our Trust Executive Committee back in April 21. We started this journey as Western Sussex Hospitals looking at this, but obviously we're now looking at it as University Hospitals Sussex. So we need to make sure we're clear about it, the stroke services at Worthing, St Richards, and any impact any change might have on the services at Brighton. So just wanted to say before we got into the meat of it around the acute section, what the other elements were. So we've got, unfortunately, we don't do very well in terms of West Sussex, in terms of either prevention or rehabilitation. It's patients, particularly in terms of primary care, there are significant numbers of GP practices who don't identify patients with atrial fibrillation in West Sussex. We're a broadly affluent area with a kind of broadly static GP kind of population, and you would expect us to do a lot better than we actually do in West Sussex. So there is an issue around that needs to be addressed, and the CCG are putting in, or have put in, a kind of incentive scheme for GPs to make sure that they identify more AF patients. The area where we're a real outlier is in terms of rehabilitation. So we have what almost every other area has is something called early supported discharge services, ESD. So this is looking at patients who are currently in hospital with having had a stroke, that could be discharged and cared for at home. What this does, the lack of this, not good for patients, but it also means that patients stay in our hospital longer than they need to in terms of their stroke care. So if you look at our length of stay for stroke care, it's longer than some of our peers because we don't have that service. We also don't have community-based rehabilitation beds in West Sussex. So for example, in East Sussex, they have a full service. They have a unit called the Irvine unit, which is specifically designed to look after stroke patients. So they see, on the patients that they discharge from East Sussex, they see 1/3 of them going to early supported discharge, 1/3 going to community-based rehabilitation beds, and 1/3 going straight home without any need for any further care. So they're able to, and their length of stay for stroke patients is around 10 days. Ours is around 16 or 17, and that's the difference between the two. We are better served for specialist rehabilitation services. We have services at Donald Wilson House at Chichester, which sees in relatively equal number patients from Chichester and Worthing, and we also have the Sussex Rehabilitation Centre, which is on the PRH site in Haywards Heath. We don't see the very highest care of specialist rehabilitation, that still goes out of county. I think we use Putney for some of that, but we do have those two services on site. So where are we in terms of our own services? So what I've always been keen to emphasise on when we review our stroke services is this is no burning platform for the Trust. We think we provide excellent stroke care from both Worthing and St Richard's, and we generally score an A or a B on our latest SNAP ratings. At the moment, it's A for Worthing and C for Chichester, but that does fluctuate a bit from quarter to quarter. Where we don't meet the highest standards for stroke care is on a number of areas. Number one, there is a recommended minimum that in order to maintain your skills and maintain your kind of rotas, that stroke units should see a minimum of 600 strokes per year. So we see just over 500 at Worthing and just under 500 at St Richard's. So we're not a million miles away, but we are short of that minimum 600. I think the worst part of the service, though, is the lack of consultant, the lack of a 7-day service. So we don't provide consultant cover at weekends. So if you're admitted with a stroke on a Friday after, late Friday evening at St Richard's or Worthing, you'll be seen by a general physician over the weekend, but you may not be seen by a stroke physician until Monday morning, and that's far from ideal. So there's also the mini stroke service, our TIA service, only runs on weekdays rather than being a 7-day service. And finally, all our kind of rehab services generally are run on a 5-day-a-week service. So you don't get the therapeutic input, speech and language therapy, occupational therapy, physiotherapy. You don't get those services on the stroke wards at the weekend. So in Brighton, we've moved to a hyperacute service where you do get all of those services and 7 days a week. So that's what we're looking to improve. So so what we've done is that we have been going through a kind of review. Or just before I get to the review, just for the I can circulate this back. This is just a little bit of a kind of compare and contrast between Worthing and St Richard's, where we in terms of the numbers of beds and admissions, etc. I'll just say a little bit about the Royal Sussex County Hospital Service. So this is the service at Brighton is a step up from the kind of acute stroke unit, in that it provides what's cled thrombectomy. So you'll probably heard of thrombolysis, which is the kind of administration of a clot busting drugs in order to get rid of blood clots. Thrombectomy is where we actually go in and operate, and we surgically remove those clots, and it's a fairly recent new intervention, and has very good outcomes for the patients that it does. So, but you do need to be on the same site as your neurosurgical unit, and you need to have the right interventional radiologists to help guide the surgeon as well. So it really effectively tends to exist only at the specialised centres. There's clearly centres in London. The nearest centre to us other than Brighton is Southampton, and at the moment patients requiring thrombectomy who are admitted to St Richard's are transferred on to Southampton, whereas the Worthing patients are transferred to Brighton. Okay. Shall I carry on? please, if you want to ask questions as we go, please feel free. But so,
yeah, sorry, Oliver, we've got a question from John Todd. Oh, and Callie.
I was just going to ask, we didn't have 24/7 thrombolysis at St Richard's. Has that changed?
oh yes, it has. That changed about 3 years ago. So 3 or 4 years ago, John. So St Richard's now runs a full 7-day-a-week thrombolysis service, which so we used to have on the weekends when patients were identified as potentially needing thrombolysis, they would go to Portsmouth for that.
Yeah.
But that's now stopped, and that's up to the figures that that means an extra around about 50 to 60 patients a year who were going to Portsmouth for that treatment are now being treated in St Richard's.
Yeah,
which is great.
And do we have a nurse specialist? Do we have a nurse specialist at St Richard's? We didn't at one point.
Yes, we do have the nurse specialist at St Richard's, and the thrombolysis services run across the 2 sites using telemedicine to help, so that we don't. You've got the administration happening on both sites, but it's aided, it's supported by telemedicine. So it's kind of a bit of a workaround in terms of being able to provide it across the 2.
Will you come on to the SNAP figures, or?
I wasn't going to cover those in
more
detail. No,
it's just that they were always lower at St Richard's, of course, than they were at Worthing.
Yes, it's so it tends to vary. I think you're right. Historically, there was something. At the moment, Worthing is an A and St Richard's is a C. The previous quarter, they were both Bs. On the whole, I think you're right. I think St Richard, Worthing does score slightly higher than St Richard's, but it's not the disparity that it used to be, because not least because we've introduced thrombolysis over at St Richard's.
Okay, thank you.
Thank you, John. Callie?
Yeah, Oliver, good afternoon. What I was going to ask was, you gave us the numbers for Worthing and Chichester. Do we have the numbers between PRH and the county for the annual number of patients?
So yeah, so we don't provide the stroke services at PRH anymore. So they all come to Brighton. The numbers of strokes coming to Brighton, there is a further slide that I'll demonstrate that. It's around about the 650 mark, so above the 600, but not significantly above it. So yes, it's interesting.
Okay. Thank you, Callie. Back to you, Oliver.
Thank you. So we started. We've been going through an options appraisal in terms of looking at a long list of options that we would want to consider as how we would go about improving our services. So we need to obviously include a do nothing option in just for comparison. Option 2 would be about setting up 2 fully compliant units, both at Worthing and St Richard's. So clearly that would be, in the public eye, the potentially the most popular, that both services are enhanced and improved. There's then options 3 and 4. Option 3 would be to have the main site at Worthing, with option 4 being having the main site at St Richard's. I think the difference between 3A and 3B is the A options would split the care of patients. They would just have their acute care, the first 3 or 4 days of hyperacute care at St Richard's, and then Worthing patients would be transferred back to Worthing. And whereas the B option is you would receive your full acute stroke care at the receiving unit, and you would only be you would only go back to your local patch for rehabilitation, whether that's in the hospital or it's in the community. So it has caused quite a bit of confusion, this. So effectively, you think about option 3 being the Worthing being the main site, and option 4 being St Richard's being the main site. So so that's the process that we kind of set up. We then looked at, and this is a summary of how we might go about assessing each of those, and we used our patient first domains in which to do that and undertake an assessment of those. And as you can see, just across, I won't go through it in detail, but making sure that we were looking at the patient experience, our staffing, the quality of care we would provide in terms of being able to meet the national standards, sustainability in terms of financial viability and the capital costs, and systems and partnerships around making sure that it's something that we could integrate across with partners and be able to deliver. So back in November, we had a quite a detailed options appraisal session, and I'll try and blow this up a little bit because it's quite hard to read, but essentially we assessed them whether or not they fully met, partially met, and or oh, sorry, can you still see that? Sorry, I've lost it on my screen. So whether it fully met, partially met, meets, or doesn't meet those criteria. So first of all, the do nothing option was got a lot of does not meets in terms of in terms of patient experience, our staff, the quality. It really did not score well against the criteria. Option 2, which was the 2 ASCs, struggled on a couple of main fronts. Number one, it was around the staffing of this, and we were really the staff involved felt we would really struggle to be able to recruit to and retain staff where the numbers of patients coming through weren't sufficient to do that. So there was a real issue there. The second issue was around sustainability. If we were to set up a 7-day service with full consultant cover, full therapist cover, etc., just covering at both Worthing and Chichester, it would cost a lot more than what we're currently providing, and we would really struggle. So we didn't feel we could do that. Now we need to be able to, when we get to a kind of public consultation phase, we're going to have to make sure we can articulate that really clearly, because a lot of people want, I mean, everybody wants world-class services on every street corner, don't they? And it's just about making sure that there's an issue about potentially needing to travel further in order to receive those world-class services. I'll pause there because I think Doug's got his hand up.
Yes, it was about the growth in the number of cases. Has it been growing over the past few years? And if you're trying to do prevention, how do you see the future? Is it going to continue to grow, or is it going to drop?
Yeah, it's really difficult to tell. So we've done there's two factors at hand. There's improved prevention and lifestyle changes which are acting as a kind of downward pressure on that. But there's also the fact that our population is getting increasingly elderly, and that's putting an upward pressure on it. If we look historically, and I'm going to put the COVID years to one side because there was some strange anomalies there, but generally it's been staying more or less even. in our modelling, we've erred on the side of caution and assumed a 2% year-on-year growth, because what we don't want to do is come up with a solution that's not sufficiently large to accommodate that growth. So, and that 2% isn't just plucked out of thin air. We've looked at how our population is going to grow by population cohort, and that's the kind of likely increase we would see if prevention didn't get any better. So, Francis.
Thank you. I was just wondering whether or not there was sort of any weighting at all on any of these criteria, or whether they were, you know, just a sort of some indicators, if you like, that then you debated or whatever. And
yeah,
I quite appreciate you've got to have the staffing, but I've got a recent experience. My daughter has actually had a stroke 3 weeks ago, so I've actually had experience of the service in Brighton and now in Haywards Heath. And as a visitor and as well as observing a patient, I think the issue about being able to visit somebody who's had a stroke, particularly to help with their communications and cognitive ability, and indeed help with movement, encouraging movement, it's quite important that it's doable as a visitor. It's not just a sort of you know, a friendly visit. It's actually part of the therapy.
Sure.
And you know, I'll be quite frank, I'm finding it quite difficult to get from Brighton to Haywards Heath on a daily basis, because it's a round trip of 3 hours with just an hour's visit, you know, so it's quite difficult, and I'm sure that'd be the same for everyone. And rehabilitation can go on for quite a long time. So I'm just wondering how the weighting of those sorts of things, and you know, the nuances there are weighed up with, obviously, you know, you've got to be able to staff. I totally appreciate you've got to be able to, you haven't got any staff, you haven't got a unit, have you really? So how the weighting happens on
yeah, so I think
these various components.
So this was effectively, there wasn't specific weighting applied to this. We're now going through a process of weighting that and looking at the remaining options. This was a kind of almost a long list to a short list that we were going through, Francis, that exclude it, because we just didn't feel it would be the advice from the kind of the clinical senate and the NHSEI was that you can't move if you think an option is just not viable, that you can't move forward with it and take it to consultation, because it's not right to take to do that. So
I mean, it's never going to happen. Yeah.
Happen. So there was a strong feeling from the staff, and that we would not be able to maintain 2 units, one at St Richard's, one at Worthing, that was fully compliant in terms of staff. So I think there wasn't a weighting applied to it, but there was almost a kind of gateway through which it didn't get through the viability gateway in terms of that. But I think, but you're absolutely right. If in terms of patient accessibility, you'll notice that on line 3, how does this option meet the criteria in terms of accessibility and improving health inequalities? The 2 ASC model met that fully, and whereas some of the other options, the B options, only partially meet that, for the very reason you say, is around some of these options will make it slightly more difficult for patients and carers to visit their loved ones in hospital. And it's one of those kind of, you know, as I say, things you need to weigh up against that. I'm very sorry to hear about your daughter, by the way, Francis. Is she in Sussex Rehabilitation Centre?
Yeah, she's at BRH now.
Yeah.
She was in the hyper acute stroke unit for 10 days and then has been transferred. So,
right. Okay.
Thank you.
No. Oh well. I hope she recovers well.
Thank you.
Francis. Okay. So just going back to this, you'll notice that the option 3A and 3B and option 4A and 4B are designated as requiring further consideration. You will notice, however, that the option that is having the ASC at Worthing does have rather a lot more does not meet around the sustainability and the systems and partnerships elements. And I'll come back to that in a second. Okay, so the next slide shows the modelling that we've done in terms of what would happen to patients were there under the two main scenarios that we would be considering. So this is the Worthing element, and as you can see, it's got the 530 odd patients that currently go to Worthing in the middle. If there were no receiving Worthing unit at Worthing, they would split almost roughly 50-50 between going to the Royal Sussex and going to St Richard's Hospital. So St Richard's would go up from having just under 500 cases to about 750, and the Brighton service would go up from about 630 to 900 cases. And the other services that we are close to would not be impacted greatly. The St Richard's case is different. So this would be if there was no receiving unit at St Richard's, and the two hospitals that would be affected there are the Queen Alexandra Hospital in Portsmouth and Worthing. So and as you can see, there's quite a difference between the split on this one. So around 75 to 80% of the cases that would go to St Richard's would end up going to Queen Alexandra, and we would get an extra 120 odd at Worthing, but we'd lose quite a large number out to Queen Alexandra. And this work has been done by the Ambulance Trust, and we've verified it. It's effectively it's because according to the Ambulance Trust, patients, the Bognor population on the whole, if there wasn't a St Richard's service there, would end up going to QA by blue light rather than through to Worthing. So what we've done is we met with Portsmouth in terms of and wanted to talk to them about the potential for if we were to single site at Worthing, and that they provided. So closing St Richard's would mean an increase of almost 400 patients being taken to Portsmouth. They already see about 1,100. It's a huge department already in Portsmouth. Portsmouth were really quite concerned about that as a potential outcome, because of the reasons are down here, that they've got real challenges managing their A&E and ambulance handovers at the moment. That their existing cohort stroke patients were already struggling with and trying to develop some further case to meet current demand, and they felt that it would make their service really unwieldy and inefficient. So we're a real concern from them around the were we to single site at Worthing and not have one at St Richard's. We've also had a look at travel times, and again, I will expand this a little so that you can see a bit closer. So and these are we are doing some further work on this because we're not happy with the level of detail we've got at the moment, but this is looking at the average travel time. So not the and they appear really short, I know, but it is because a lot of people are conveyed very quickly from very near the hospitals in Chichester and Worthing to that, so that skews the average travel time down. But you can see that currently the average travel time to either Worthing or St Richards for a stroke is around 13 to 14 minutes by ambulance. If we were to not have a receiving unit in Worthing and have one at St Richards, that would rise to an average of 28 minutes. And it would be almost exactly the same if it was the other way round, which is the if we had no receiving unit at St Richards and we upgraded the service at Worthing. So very, very little difference between the two. We did ask the team that did this just to model a fourth scenario, which was, okay, if there's no receiving unit at St Richards and Portsmouth can't take any more patients, so that they had to, so we kind of took Portsmouth and St Richards out of the equation for our patients. How long would patients then wait? And you can see it goes up to 36 minutes under those scenarios. There is an upper limit nationally of 60 minutes in terms of journey time. That's an absolute limit in terms of ambulance conveyance time, and under all the scenarios we still continue to meet that, so that's a relief. So check there's no hands before I carry on. No. Okay. So the next slide was, what we've done is provided this detail in terms of a kind of pre-consultation business case to the Kent, Surrey and Sussex Clinical Senate. And this was the feedback that we'd got from the Clinical Senate. So I won't go through this in detail. I'll just pick out a couple of issues. Firstly, they could see the benefits of the centralising at St Richards, but they felt that might come at the expense of strength. The point that John was making, which was that on the whole, the current performance of the Worthing unit is better than the St Richards unit. So I think also wanted a lot more information around prevention strategies and looking at improving community rehabilitation, as well as I think they felt that the case was a bit too much focused on the acute, and there was a hell of a lot of work to do in terms of prevention and rehabilitation, as I've talked about. They talked about if there was if there was a flow of Worthing patients to the county site, how would that impact upon the service at the county? And I just wanted to spend a minute or so talking about that. So as you know, we've got incredibly challenged A&E services at the county, and under one of these options, this would end up with an extra 250 stroke patients coming to the county. However, as you know, the current stroke service is situated within the county, is situated within the Barry building. They provide fantastic care there, despite the environment in which it's provided. And Francis, you will have very recent experience of the environment there. They are one of the services that is moving to 3Ts, so they're moving into absolutely fantastic new facilities within 3Ts, and we do have the capacity, should we want it, to increase the number of beds that are on within 3Ts to accommodate those stroke patients. So our analysis is that we do have that. We'll need to obviously staff it and make sure it is properly serviced, but we do have the bed capacity to be able to move from the current 630 stroke admissions up to the 880 admissions. And I'm talking with the stroke clinical leads around, improving the stroke pathway from the A&E department and to the stroke unit as we speak. It works pretty well at the moment. So what happens is the ambulance will ring ahead and let the trust know that they've got a stroke patient incoming. The stroke consultants then go down to the A&E department and receive those patients, and those patients are transferred to the stroke ward. Now, it doesn't work all of the time, not least because they're operating out of only 23 beds in the Barry building. But once we've moved into 3Ts, we think we've got a solution that would work there. And it's a long overdue, obviously, change. And the just other concern was they wanted a bit more detail on the workforce that would support any change. I think there's a risk that were we to centralise on either site, Worthing or St Richards, that we might lose. If we centralise at Worthing, we might lose the St Richards staff and vice versa. So we're in conversations with the teams about that. We think in the long term, having a fully compliant hyperacute stroke unit would be much more attractive to staff, consultant stroke staff and specialist nursing staff, in terms of being able to recruit and retain people, because people don't, in the long term, people don't really aren't attracted to something that's not meeting the national standards. Finally, just wanted to move before any questions to the next step. So we're going through we're updating the pre-consultation business case and taking that through our governance and trust management board at the moment. The next big step is what's called the stage 2 review with NHSEI. So they will do a review of our findings and make their recommendations. We anticipate now going to the Health Overview and Scrutiny Committee in November. If they are supportive, we would go to public consultation, likely to be December to February. All these timelines are subject to change. I will have presented something to you about a year ago which had timelines which were slightly different to this, but so things have moved a little. And we would hope that we would be able to agree and sign off the full business case by March. I think April 23 is hugely ambitious in terms of that's the start of the implementation phase rather than the completion. So I don't see any changes to it happening. Probably, I think it's probably at least 18 months away, if not longer. So I'll leave it there. I'm happy to take questions. Unfortunately, I do need to go at 10 to 2, so apologies for that, but I'm happy to take any questions for the next 5 or 6 minutes.
Cool.
Thank you, Lynn, and thank you very much, Oliver. That was really comprehensive. I think you've already covered most of what I was going to ask, but it's particularly about the Barry building and the transition into 3Ts. Over about 5 years, I was spending quite a lot of time on Donald Hall and Catherine James in the Barry building. And obviously there's going to be quite a time delay between, with bringing on the new hospital and the vaporization of the Barry building. I'm just wondering about the initial part of your talk was very much focused on the western side of the patch. What you just addressed is a very considerable expansion thanks to the 3Ts. I was spent during my period on Donald Hall, Catherine James. That was when they were awarded the hyperacute status, and which was a matter for great celebration, really. I mean, you know, as you said, 24 beds, wonderful consultant staff, fantastic, and a lot of the my experiences there compared to other wards was that it was very much focused upon the necessity for visitor contact for patients, that the people who are able to communicate better with, obviously within family and friends, and there really wasn't the capacity for that. So my question really, the last remaining question is, as far as the emphasizing the new identity, if you like, of UH Sussex, to what extent the exporting patients down west to Portsmouth or whatever, whether there would be the capacity to bring more of the western side of it into Brighton, given that we have the capacity for it, and then that's something that we can advertise for UH Sussex as opposed to factoring out into other regions.
And clearly that's one of the difference between option 3. That would be one of the benefits of centralising at St Richard's rather than at Worthing, because we would then be able to create a hyperacute stroke unit at St Richard's, and we would know that the Worthing patients would either go to St Richard's or to Brighton. That's how they would divide. It's worth just saying that this isn't about transferring services from one to another. What we intend to do is create an absolutely first class stroke service either at Worthing or St Richard's, and I mean, I know that before George went to Medway, he was leading on this in terms of lead, and he didn't want to do this for the sake of doing it or because we're being told to do it. He wanted to do it because he wanted to create a brilliant stroke service across our environment. We've already got that, I think, in Brighton. The only thing that's lacking in Brighton really is the environment, and we're sorting that out with 3Ts. But we need to do that in the West as well.
Well, thank you very much. Just very quickly then to re-question on what would happen then, for example, to a Brighton stroke victim? Would that person go to St Richard's, or could they, with the advent of 3Ts, could they not remain in Brighton?
Oh no, they would all remain in Brighton. All the Brighton, under every scenario, everybody who has everybody has a stroke close to Brighton would remain coming to Brighton, Paul. Sorry, sorry if that's not been clear. So Brighton either stays the same or gets bigger under every scenario that we've got.
Fantastic, thank you.
We've only got 2 minutes, so Callie followed by John, please.
Yeah, I was going to say, I'm sorry if I missed it, Oliver, because I was distracted, in fact, by a call from the professor of stroke medicine. It had nothing to do with this meeting. It was totally something different. So, but I was just going to say, what about thrombectomies? That would carry on only in Brighton, wouldn't it?
Yes, it will. So so we're developing the thrombectomy service. At the moment, it's only 5 days a week. We're moving it in the next couple of months to be 7 days a week.
I think just for this, for the governor's sake, it is important to say that thrombectomy is becoming more and more important.
Yeah.
Whatever scenarios we create, we need to keep that in mind, because very much like what happened with myocardial infarction, where we used to give medication first, but we've now moved to primary stenting. Similarly, with stroke, carotid endarterectomy and thrombectomy are becoming much more common. So whatever we do, we have to keep that in mind.
No, agreed.
John.
Following on really from what Callie was just saying, really, that Worthing is obviously closer to the specialist centre at Brighton than it would be if it was moved to St Richard's. And what would happen if it's St Richard's and we tried to move them to Portsmouth? They couldn't cope. We'd have to bring them back even further, back to Brighton. Also, how does this fit in with our green travel if it was based at St Richard's? Because you're going to 10% more of the strokes are in Worthing area by your own figures, and it means ambulances and, more importantly, visitors are going to travel over to St Richard's if it was based there.
Yeah, so I think, so for thrombectomy, Portsmouth don't do thrombectomy, so they would go to, they currently go to Southampton, and that would continue. What would be, we would have more patients coming directly to the throm. It's best, we're working with the Ambulance Trust to see whether or not through telemedicine, they can identify thrombectomy patients or patients that are likely to have thrombectomy. So then they can be safe. They don't need to go via Worthing or St Richards. They can go. The ambulance will take them direct to either Southampton or Brighton, whichever is the closest. That's undoubtedly the best option for the patients. In terms of the impact, clearly centralising at either Worthing or St Richards has potential for an adverse impact in terms of environmental sustainability, just because the ambulances will be travelling further and the others. We need to a bit more detail in terms of the impact, the environmental impact, because we would, if we centralised at Worthing, we would have a lot of Bognor patients that would be travelling to Portsmouth, and that's that again, and their carers travelling to Portsmouth. So I wouldn't want to naturally assume that one would be better or worse than the other at the moment, but it is one of the factors we need to look at.
But we're only talking Haskew, aren't we? Well, we will still have stroke units at St Richards, even if Haskew was moved to Worthing.
We would, as I say, we would not have patients wouldn't be admitted to St Richards or Worthing if it was the other alternative. They would go to we would have just one admitting unit, either St Richards or Worthing under this scenario. So we would there would then be some kind of step down that I talked about, but not so patients would go directly to externally to Portsmouth under that scenario, or to Brighton under the other scenario.
Yeah. So has this changed then? Because it used to be the hyperacute at St Richards with still a stroke unit at Worthing, or vice versa. Presumably that has changed.
It's part of the options, but even it's only the hyperacute unit that receives strokes. So even if you have an acute stroke unit on one side and a hyperacute stroke unit on the other side, John, all the ambulances would blue light you to the hyperacute stroke unit. Okay. You wouldn't go directly to the other unit.
I'm just thinking of a case in where with more 10% more in Worthing, that if they headed towards St Richards, they couldn't handle it. Then they found out Portsmouth couldn't, end up going back to Brighton. It's is that going to get within the 3 hours?
Yeah, and that's the further travel analysis that I said that we need to do, that we will do that. I'm really sorry. I'm going to have to go now. I'm really sorry to do that. But
Oliver, that was super. It was really
thank you very much. I'm happy to circulate the slides if that would be.
Please, thank you.
Okay. Thanks very much.
Thank you.
Bye.